Hi, everybody. Thank you for joining us today for Dr. Morris's presentation, Maximize Mental Health and Substance Abuse Outcomes with Nicotine Dependence Co-Treatment. And we're going to get started at noon. I just wanted to let you know that if you have any trouble or are having any technical difficulties, just please use the chat function and send your message to me. I'm Amy Hansen, and I will do what I can to help you out. So just hang on and we'll get started shortly. Hi, everyone. Again, we had a lot of interest in this webinar, so we're going to give the latecomers just a couple more minutes to log on before we get started. Hello, everyone, and welcome to Maximize Mental Health and Substance Abuse Outcomes with Nicotine Dependence Co-Treatment. This is the first webinar of 5 that is a part of a training series offered by Oregon Health Authority's Transformation Center and Health Promotion and Chronic Disease section. So everybody is currently muted. If at any time you have any difficulties, please use the chat function to contact Amy Hansen, that's me, and I'll do the best that I can to help you out. The chat function is available at the bottom of your screen. You hit the icon that looks like a word bubble with the 3 dots in it. We will have Q&A at the end of the presentation, and there are 3 ways to ask questions. You can use the chat function at the bottom. There's also let's see, excuse me. You can also hit the Q&A icon and a window will open and that will allow you to type your question. And you can also raise your hand. And if you do that, I will acknowledge your question and unmute your line so you can ask your question directly. So thank you very much, and I hope you enjoy today's presentation. And with that, I'll turn it over to the HWP's director, Dr. Chad Morris. Chad?
Thanks, Amy. Appreciate it. Well, we're really looking forward to this this series and partnering with Oregon, and thanks for everyone for tuning in and participating in this. And I think that this topic today is one that's critical and very timely in talking about co-treatment models of tobacco and treating other substances and other addictions. Just as an introduction again, at the Behavioral Health and Wellness Center at the University of Colorado in the Department of Psychiatry, we're a whole health program. And we're really about helping folks lead the most meaningful and fulfilling life possible in the most integrated community settings. And in this instance, really helping folks change any unhealthy behaviors and overcome addictions is a big part of what we do. And we spend a lot of time working in helping address the tobacco cessation needs and tobacco control needs of health disparity populations. So just diving right in, and so really, and I use this chart quite a bit, so you might have seen this if you've seen one of our other presentations, but just setting the stage. This is really looking at trends in U.S. adult smoking in the U.S. over time and looking at the amazing population level gains that we've made in reducing combustible tobacco use and cigarette smoking over time. From, you know, on the top line, you see the men, and each yellow bullet gives you a data point we have showing you the decrease among men, and then on the bottom, on the blue points, looking at women and how they've kind of converged over time, but we're seeing this amazing public health story in that just amazing gains in folks quitting smoking over time. Now we're at about 14% nationally in adults using cigarettes. But for our purposes today, really the compelling note is that top line, is that even though we're making all these amazing gains among combustible products and really reducing those, that among folks that use drugs, other drugs besides tobacco, they smoke at a tremendous rate, and anywhere from about 50 to 90%, but that can really actually be about as high as 98%, 99% among some studies that look at methadone treatment environments. And so just extremely high rate of smoking among this population that we're talking about today. And, if you look at one of our colleagues, Joe Guidish out of the University of California, San Francisco, has done a great amount of work, wonderful work looking and studying the addiction population and really what's been going on with them regarding smoking over time. And he did a really nice, really series of studies, but showing again that from 87 to 2009, the annual smoking prevalence in these addiction programs is about 76%. So for those folks coming in for treatment, it's just another example of how high the rate of smoking is among these individuals when they come in for help. But they also, the addictions populations really cross across a lot of folks that in other populations that are at really high risk for smoking and facing the unnecessary death and disability that goes with that. And so, we were talking initially about behavioral health, which encompasses both mental illnesses and addictions, that smokes at 2 to 3 times the rate of the general population, but also the LGBTQ community, as well as those that have HIV/AIDS, smoke about that rate. The homeless population smokes at very high rates. We work a lot with the justice-involved population, and they smoke at about 3 times, really 3 to 4 times the rate of the general population. Veterans, you put them in the mix. They're not on this table, but and they smoke at about 3 times the rate. And there's a variety of other health disparity populations. And the point really is that we're really not, when we're talking about addictions, we're really talking about populations that usually cross more than one of these risk factors that really puts them at multiplicative risk for, again, facing death and disability due to their high rates of smoking. And to set the stage again, I think it's really important to look when we're talking about co-treatment models. Right now, obviously, the opioid epidemic is very much in the press. It's very much on people's radar, and rightfully so. I mean, it's just the tremendous amount of deaths rising from about 33,000 a few years ago to over 70,000 a year right now. Demands and warrants a lot of attention at how we can effectively address these individuals that are in high need. But that said, this really actually, the opioid epidemic also really affords us an opportunity to talk about and address polysubstance abuse, and including tobacco. And because we don't really want to lose track of other drugs and tobacco and the effect and the implications that they have. Often, I've really felt like alcohol, for instance, has dropped off the radar a little bit, but again, we lose more folks due to alcohol than the opioid epidemic at this point. And then when we turn to tobacco, that's very much the case. And so we know that if right now in the United States alone, we're still losing about 480,000 people a year due to tobacco use. If you compare that to all these other causes of death on the right-hand side, and even you notice that drug-induced says 43,000 individuals. We'll say we up that again to about 74,000. It still doesn't get anywhere close if you add up all these leading causes of death to tobacco. And so we really don't want to lose track of the fact that even though it's not sometimes imminent, life, it's not possibly going to cause a death that day. This tobacco remains the leading cause of death in the United States. And if you look on the left-hand side at the black line, that's a really important point because that's showing you that about 200,000 of that 480,000 deaths per year are individuals with behavioral health conditions, so the population that we're really wanting to discuss today. And, historically, when I've worked quite a bit in inpatient and outpatient addiction settings, there was really a feeling historically, and it wasn't that long ago, so if I go back about 4 years, 5 years, there's still a lot of concern out there that if we ask folks to quit smoking, that their psychiatric symptoms were going to get worse. They were going to be exacerbated. And so that's the last thing we wanted to do, particularly when someone was coming into an addiction unit, and they were a treatment unit, and they were trying to kick their heroin use, or they were trying to address their cocaine use. The last thing we wanted to do was really increase their psych symptoms. So there was really, and at this point we really know it's pretty much a myth, because at this point the studies are continually showing that smoking cessation is actually associated with much less psychiatric symptoms and much less stress. And it increases positive mood and quality of life. And really, quitting smoking can have the same effect size as if you were using something like antidepressant treatment for mood and anxiety disorders. And so this is, one study I'm presenting, Taylor, who did a really nice job of a meta-analysis looking across many studies and showing this, but this is what we're finding over and over again. So there's that historical myth that we still bump up against, and it's not completely, there are some cases where we do have to be cautious, so it's not completely untrue. So if someone has, a lifelong instance of major depression, suicidality, things like that, we have to be a little more careful. But if they're quitting smoking, but in the mix of the whole patient population, this is what we're finding when we're dealing with folks coming in for treatment. So the bottom line too, that I just continue to say over and over again, is an addiction is an addiction is an addiction. And this is what we find when we talk to folks that have major addictions coming into treatment environments, is that if we ask them what their hardest addiction to give up is, almost 100% of them are going to say tobacco if they're tobacco smokers. And if we're not addressing that addiction alongside other addictions that they might be coming in primarily for as far as their treatment needs, we're really directly or indirectly condoning and extending coping through addiction. And I'm going to get a little more into that. But the cross-priming and cross-tolerance among these different addictions is very strong, and the evidence definitely shows us that co-treatment is the way to go. So if we listen to the Surgeon General and his report 2016 and what's been said from the Surgeon General's office since then, as well as the evidence base coming out, the Surgeon General says directly co-treatment is the only adequate solution to addictions. And that's because the biopsychosocial underpinnings of these addictions are so similar. And so they're really unrelated to a large extent to age, sex, race, ethnicity, gender, identity, or culture. And so again, it's getting back to that notion of an addiction is an addiction is an addiction. We're going to look a little bit at treatment and how treatment is very similar across these different addictions. And again, it gives treatment professionals a real opportunity to more efficiently and effectively address a number of issues people are bringing in the treatment at the same time. So another meta-analysis, just much like the Taylor study that I was talking about earlier, is that we also know that if you're addressing tobacco dependence during treatment for other substances, you're going to have much better outcomes, about a 25% increase in long-term abstinence rates from alcohol and other substances. And so Prochaska did this study in 2004, but there was another recent study that replicated this. So this was a meta-analysis of 19 studies, and another meta-analysis just recently replicated the same types of findings. So we're looking at if you co-treat, and what this means also in a treatment environment, it doesn't mean that you're necessarily treating these issues in the same moment in time, but they become part of a treatment plan, and you're addressing this as part of the episode of treatment, or while during their stay in an inpatient type of setting, for instance. And another thing that comes up too among this population is, the question is this a social justice issue? And so often historically, just like some of the other myths that I'll be talking about, there's this notion that these individuals didn't want to quit smoking. And that's really what we're finding to be a false perception. And so if we've done our own studies, this is one of our studies from a recent community of practice that we did in Florida, looking at inpatient substance abuse units. But we find this time and time again and this is exactly the same rates that we're finding with the mental health population. And this is on par with what you find if you just ask the general population about what their interest is in quitting smoking. So only about a quarter of folks, if you ask them this question, have no interest in quitting. So the majority are somewhere else. They've never used, they used but quit, are, a large proportion of them wants to quit. And again, so if we ask this question, is this a social justice issue? My answer would be yes, because if the definition of social justice is some state of egalitarianism, and what we find with this population is they're typically not given the same opportunities for treatment or access to treatment for their tobacco use as some of the other, quote unquote, general population. So this to me is a classic example of what a social justice issue would be. And another, so if we extend beyond that, so these individuals want to quit smoking, we're going to show that they actually can quit smoking in many regards. Again, we have this real opportunity to look at co-treatment across a variety of polysubstance use. And this really makes a lot of sense in our current environment. So, for instance, with the burgeoning use of marijuana among some populations, and we'll look at some of the map of what's going on as far as legalization, but then also with ENDS use, so electronic nicotine devices, and then combustible cigarettes, on top of things like opioids. All these things really, again, polysubstance use is the norm. It's not the exception. And so we know, for instance, in Colorado, unfortunately, we have the largest proportion of kids using electronic nicotine devices, and among those, about 1 in 4 kids use, they vape or they juul, and among those, we know about 1 in 3 use their ENDS products to actually smoke or vape marijuana. So all these things are really kind of overlapping at this point, and again, it provides that opportunity to address these together instead of separately. And then we also know, in just setting the stage for what we need to do with treatment, is that we often talk about how drugs and so forth hijack the brain and lead to different neural pathways, et cetera. And that is very, very true. But also we need to look at the other social determinants of health, and some of the big ones being, medical care, access to medical care, the physical environment. Are people in community? Do they have connections with others? Are they isolated? And so these are some of the treatment factors that we need to bring into play, in addition to the pharmacology that addresses some of the biological and physiological aspects of addiction. And if you look across addictions, again, with tobacco in that mix, so anytime I say addiction, I mean tobacco as well. Really, it's the same set of the social determinants and social issues and variables that lead to addiction. So everything from chronic stress and toxic stress that we deal with a lot in our treatment setting, looking at young families that have toxic stress, but looking at coping skills and industry targeting is a huge issue. Stigma, low SES, so stigma both on the side of self-stigma, but then also stigma when it comes to the communities and providers as well. And the other reason why co-treatment makes just a lot of sense is that we're often talking about exactly the same neural pathways. And so when we're talking about something like tobacco and we compare that to cocaine and opioids, it is almost exactly the same pathway in the brain, the dopaminergic system that we're really addressing. Marijuana is a little different, and some other drugs are different, but man, the similarities are so striking when we're dealing with opioids, cocaine, alcohol to some extent, and tobacco. And so it's really pointing out that both on the physiological side and as we'll see on the behavioral side, we have this opportunity because there's so many similarities. And if you look at addictions generally and coping through addictions, just like when we ask people about their tobacco use, the majority of individuals that are using substances recognize they're unhealthy and life-threatening. Obviously, they're getting something out of them or they wouldn't be using them. And a lot of times they mistakenly believe that these drugs have positive psychological functions. And just like tobacco, a lot of drug use is really trying to get relief and avoid stress, anxiety, and depression. But again, it's an indirect coping strategy. Using any of these substances reinforces coping through addiction. And often the perceived stress reduction is often just relief of withdrawal symptoms. And with something like tobacco, unfortunately, what a lot of smokers don't understand is that if they're trying to avoid something like stress and depression, they're really shooting themselves in the foot because we know through the evidence base that over time, among tobacco users, stress and depression actually increase, they don't decrease. And then when we get to ends, I mean, this is just so prevalent right now that I feel like we could do one or two presentations on this alone, but it's important to bring ends into the mix with all the attention paid to juuling and again, this overlap in polysubstance use of vaping products as well as tobacco. And so there's all these different products and there's a lot of back and forth about from a population perspective, do ends actually help with cessation? And that's not, a conversation that I'm really trying to get into today, but I would like to point out, and a lot of you have seen this, that the main concern is among youth that are using ends and among those youth that never smoked. So the never smokers that are using ends products and juuling are about 42%, and some are about 43% are currently dual using. So basically the concern is that we're really imposing a drug on a growing brain, but also we're probably priming that brain for use of other nicotine products, and as we'll see in a minute, really use of other drugs of abuse as well, but particularly opioids. And then with marijuana, of course, you have to talk about that. We're the poster child of marijuana use and recreational marijuana use being in Colorado. So all the lime green states you're seeing are those that have recreational use. Those with dark green are those with medical marijuana. And this was 2017, so this map's rapidly changing. And in the coming legislative session, it will be interesting to see how the map changes even further. But the point is that just how fast this is growing and what does that mean? Well, with adults, it's kind of unclear what the implications are for marijuana use as far as the potential negative effects. We know there's more car crashes, that's for sure, and auto accidents among both youth and adults. But again, the primary concern is among the youth. So we know that there's a significant decrease in the mean age of first marijuana use. And if you look at why the youth are being admitted to treatment in inpatient settings, it's the major reason for that is marijuana use. And if we look at statewide data sets, the youth are also telling us that they perceive marijuana to be less harmful, and disapproval of marijuana use is going down. And so this is probably the opposite of what we're seeing largely in regards to combustible products and cigarette use. But it will be interesting to see what happens over time. And we know that if kids are using marijuana on a regular basis at an early age, there's all sorts of implications, including lower cognition, anxiety, accidents, risky sex. And then there's those classic studies looking at drops in IQ as well. So it's very clear that kids might drop as much as a standard deviation of IQ if they're regular tobacco users at a young age, and even if they quit, over time they don't seem to make up those IQ points. So that's lost for good. So this is a major concern among kids that are using marijuana quite a bit. And then there's the opioid epidemic. So again, this has been the prescriptions that have led to a lot of the illicit use is clearly documented by the Surgeon Generals and others, and the opioid epidemic is in full swing still. Some states are making gains, other states aren't. But the really interesting thing that I've done a lot of delving into and really looking hard at the evidence base is the interaction between opioids and smoking. And so that we know that there's clear interaction between opioids and smoking. So very interesting that if youth smoke, they are much more prone to have chronic back pain, which leads them over time to be prescribed opioids, which often leads to, as we know, long-term, if you're prescribed opioids for pain, leads to illicit opioid use. And so, even at a young age, kids could be priming themselves in the sense that they have this chronic pain for use of opioids. But then there's also neurological priming and tolerance, and this is bidirectional. So we know that smoking primes individuals to use more opioids, and that's both the illicit opioids, but also methadone and buprenorphine as well. And so the treatments for opioids, if you're smoking, you're going to be more tolerant of those medications and have to use more of them as well. And this is in turn leading to treatment outcomes for smokers. So if individuals are in an environment that's not tobacco free for their opioid treatment, they're actually going to see more increased opioid withdrawal, increased cravings, lower detox completion, etc. And so there's this real relationship between these two drugs. And part of it's really metabolism as well. So if people are smoking combustible products, what happens is that combustible products have polycyclic aromatic hydrocarbons in them that really lead to, in the liver, to metabolizing both nicotine faster, but also the opioid medications faster, and therefore you need more opioid medications, or you need more illicit opioids. So there is some fear that if individuals that are smoking quit really quickly and their providers aren't aware, that they could become toxic or even overdose on some opioid medications. So again, we know that quitting can be done. Not only do individuals with behavioral health disorders and conditions want to quit smoking, they can quit smoking. And often we find in studies that we've done and others that this population is often more motivated than the general population to quit smoking. And about 65% have tried to quit smoking in the last 12 months. But it's just really contingent, their ability to quit smoking, on accessing and really using proven treatments at appropriate dosage. And that's both on the behavioral health side, but then also on the pharmacologic side. And so let's move into treatment. So what do we do with this? We see all these co-treatment issues and the foundation that we've set in that regard. So we really look at setting a foundation of whole health initially, and looking at across different wellness types of issues, not just focusing on the physiological addiction, but really looking at these other components of wellness as well, and really looking at the whole person and really integrating that into any kind of treatment environment. And so in our programming, but we see this a lot of this happening nationally with other programs as well, is really focusing on such things as healthy eating and physical activity and stress reduction and sleep. I mean, sleep, just as one example, we know that there's a clear connection between tobacco cessation and sleep. There's a recent review that just came out this month on that, showing that, if you're a tobacco user or you're trying to quit smoking, that you're going to have a harder time with sleep. And so we really need to look at interventions that help folks in that regard, because if they don't get that help, they're much more likely to relapse. So, and to their smoking and to other addictions as well. So that's just one example of why this kind of whole health approach is really important as we look at co-treatment. But then our other foundation is really awareness building, and we focus a lot on motivational interviewing strategies and really helping folks build the self-efficacy and the change talk to really move towards their change goals. And so that's really the foundation of everything that all the interventions that we pose. But then really we know from a co-treatment perspective that motivational interviewing works across the board. It really is a foundation for treating any kind of addiction out there. And it started with alcohol and tobacco and moved on to a lot of other drugs of use as well. And so we use semi-structured interviews to increase readiness and provide personalized feedback about carbon monoxide levels using the CO monitor, and encouraging concrete and manageable goals as part of our motivational interventions in co-treatment types of environments. But the other thing we can do, and it's a real foundation, is look at in the tobacco world, we call it the 5 A's. So ask, advise, assess, assist, arrange. But if we compare this to what's going on with other addictions, similar models are used in many different environments, and typically they're called something like SBIRT, so screening, brief intervention, and referral to treatment. Well, that's exactly the same thing as the 5 A's, and there's even other takes on this. There's something called STIR, which is screening and really getting brief interventions into place and then referring. And this is just a way of saying that I think a part of why tobacco hasn't been integrated into other co-treatment models or other substance use models is that the public health world around tobacco just spoke a different language, sometimes speaks a different language around treatment, but it's really, when you get down to defining what's going on, it's exactly the same thing. So it's really important to screen, assess, and not stop there. Get people into treatment either at your agency or at the same time referred to community resources out there. And to really integrate this in the standard practice, so make it part of the cessation, as part of your treatment plan in a polysubstance use type of setting, really looking at making sure that tobacco is a piece of that treatment plan and part of any kind of registry that's happening, or EHR that's happening as well, and synthesizing those results in a way that makes sense to clinicians. So that's a lot of what we help do. And then when we actually get into treatment, looking at both, we know that whether it's tobacco or any other drug, there's the physiological aspect and the habit, but there's also but there's the physiological aspects of the actual addiction, but then also the behavior of the habit that we have to address in both cases. And any evidence-based treatment is going to really look at both of those. And so when we get into the behavioral strategies and we look at treatment for tobacco, or we look at treatment for other drugs out there, the behavioral treatments are pretty much the same. So it's going to be cognitive behavioral therapy, contingency management, and motivational enhancement. And so, again, you can mix. There's no reason to put tobacco in a silo when you're doing treatment. You can really mix it in the treatment of any other kinds of alcohol drugs that you are trying to intervene on. And then in the school-based, at a youth level, school-based interventions are very similar as well. And so when we look at something like our group curricula for tobacco use, this looking at our 6-session type of structure that we use for tobacco. But when we compare this, and I've done this comparison to other types of psychosocial group interventions for other addictions, and I've run these types of groups for many years, the overlap's about 80%. And so again, there's really not any reason to exclude tobacco from group interventions that you're doing, and it's pretty easy to just mix it into what you're already doing. So it can be a much lighter lift than just adding a whole new kind of treatment curricula. You can really look to integrate tobacco into the whatever practices you already have in place in your treatment environments. We also know that using peers across types of substance use is very effective. And so we found that to very much be the case with tobacco, but it really began more with mental illnesses and other addictions. And so there's a lot of nice guidance out there. We've provided some guidance for organizations that want to use peers and the steps that you should just consider when you're hiring peer specialists to be part of your treatment team. And then when we move to the physical side and pharmacology, it's like any other drug. We know that if we're not controlling withdrawal effects, the rest of treatment can be extremely ineffective because people just do not feel good and they're not going to benefit by a lot of the other treatment that you're trying to offer them. And so with nicotine, it's all the benefits that people get out of nicotine when they're in withdrawal. It's the exact opposite of that. And that's what we find with a lot of other drugs as well, of course. And so really what we're getting at is that tobacco applies equally as a medication-assisted treatment as if you were treating opioids or you're treating alcohol. And so MAT, again, we typically in the tobacco world, we don't call what we're doing MAT, but it is exactly what we're doing. So we're mixing those behavioral elements, the behavioral treatments with FDA-approved medications. This is another reason why we just need to kind of start trying to talk the same language a little more, and I think we'd be much more effective in what we're doing. So with tobacco, of course, we have these as the FDA-approved medications. So we have our 5 nicotine replacement therapies, but we have bupropion or Wellbutrin, and then varenicline or Chantix as well as part of that MAT process that we can use. And the main issue that we found when we're working with agencies on MAT, with tobacco specifically, and really integrating that is cost, because we have to look at things like nicotine replacement therapy that have not been historically paid for by your funding sources. But there are ways around that. And then training folks to use this pharmacotherapy appropriately. The main reason that pharmacotherapy for tobacco doesn't work is it's typically underdosed and it doesn't meet dependency levels. So if providers and prescribers get that training, they can be very effective. And then looking at workflows and how to really build a sustainable and scalable model. And then there's this perceived liability often with nicotine replacement therapy and other cessation medications that really it's very much overstated, and there's a lot of workarounds about that. But people are concerned even with NRT that they might be causing heart attacks or, for instance, cardiovascular events with some of their patients that they're working with or clients. And that very much is, that's NRT is about the safest medication you can use. So it just involves training. And then looking at referral mechanisms and building those into co-treatment, as we spoke to that as part of ESPERT, or whether you call it the 5As. But for tobacco, it's really making sure people are using resources like their Stay Quit line, but then with other drugs, making sure they're hooked up with any other community options out there, and looking at things like AA, but AA environments that are non-smoking. And then we're also very much in delving into what we call the client-centered medical neighborhood. We're now at the point where we're calling it the health neighborhood, not even the medical neighborhood, and looking at what is a necessary continuity of care for co-treatment that's really going to extend the benefits of this. Because we can't, if you're in an inpatient unit or even an outpatient setting, you cannot provide all the services necessary and be available for a person to the extent that they need. And so what is the continuum of community partners that need to be on board and have the same messaging and leverage each other to make this happen? And so we're working to make co-treatment models much more effective by working with the criminal justice system, quit lines I mentioned, homelessness environments, et cetera, just to look at what scope of work each one of these partners can play and how they combine in a way that really is going to lift up the person and support them over time. The last piece that I wanted to just mention is policy intervention. So along with that health type of neighborhood model, really historical tobacco-free policy models are getting much broader because of the polysubstance use and the overlapping use that we're seeing. This is a sign that's actually from my town that I live in, Fort Collins, Colorado. But you'll see that on these signs, it's no longer just the combustible cigarette that's X'd out. It's marijuana, and it's the ends and vaping products as well. And this is where we're really going to and working with a lot of sites in looking at how to address polysubstance policy instead of just one policy at a time. And we know that with tobacco policy, if you have that in place from a campus perspective, and Oregon's done a tremendous amount of work in this regard, that is going to dramatically increase cessation and support abstinence over time. We have a lot of resources out there to support and speak to a lot of the points that I brought up today, and I welcome any kind of literature that I can provide on this as well. But we have our toolkits for healthcare professionals and our policy toolkits. We have toolkits looking at workflows, and you can just go on our website and pull those down for free and disseminate those however you would like. If you're not a member of the National Behavioral Health Network for Tobacco and Cancer Control, we're one of the agencies that help run that. Please join up. It's one of the CDC networks for disparity groups, and it's a great way to just stay in the loop as far as new resources, training, options coming down the pike, things of that nature. And then for those of you who are treating tobacco, if you're not part of ATTUD, the Association for the Treatment of Tobacco Use and Dependence, again, I highly recommend it. The behavioral health population is a discussion that's constantly on their listservs and so forth, and I've learned a tremendous amount through that listserv alone. So I just highly recommend it. It's a very small fee to become an ATTUD member, and I think that there's a lot of benefits to it. And this is us. So if we're not able to get to your questions and so forth today, you're always welcome to contact us, and we'll try to get back to you as quickly as possible. So with that, what I think I will do is I'm going to hand it back to Amy, and Amy's going to share some of the questions and comments, and I'll try to answer those as best I can.
Thanks, Tad. So like you said, we'll open this up for questions. I didn't see any in the chat area. So if I missed one, if you could please enter that. So as I mentioned earlier, to ask questions, you can use the chat button or the QA button at the bottom of the screen, or you can raise your hand and I will unmute you and you can ask your question. So are there any questions? I see one. Okay, go ahead, Cynthia.
So I was just curious if we are able to get a copy of this slideshow, because there was just so many good facts and pieces of information in there. I would love to get a copy of that. Will you be sending that out?
Yes, so we'll make that PDF available to everyone that was attending the day, and I think we actually might even have it up. Are we going to, Amy, do you know, are we putting it up on our website as well?
You know, I would have to discuss that with Jim, but I'm assuming we are.
Yeah, but bottom line is yes.
Yeah.
Thank you.
Yeah. So,
are there any more questions?
Yeah, don't be shy if you have any questions, or even if comments, or if you have a different perspective.
Oh, so it looks like I'm kind of getting them. It's taking a little while. So Larry asked, is there any alternative to Chantix?
Larry, did you mean outside of Wellbutrin? I don't know if you can unmute Larry.
I'm looking. Okay, Larry. Can you?
Larry, are you unmuted now?
Should be.
So I'm not quite sure if I'm going to answer your question now, but basically a lot of combination therapy is the way to go. So a lot of people start with different combination NRT with gum and with the patch. Often even people use a combination of varenicline. There's several studies, the evidence is mixed, but they'll use Chantix in combination with NRT. And you would think that that's strange because they should actually, Chantix should block NRT, but it's actually working on other nicotinic receptor sites. But if Chantix isn't working, or individuals have side effects that they can't tolerate on Chantix, I would first go, and they've tried NRT as well, I'd look at Wellbutrin and see if if that's contraindicated or might work for them.
Okay, so Paul asked, it says we are an insurance provider, OHP Primary Health. They want to start smoking cessation groups here. What is the best smoking cessation evidence-based material to do that?
Well, I'm a little biased because there are a few different programs out there. We have our own program that is a 6-session open group structure. We've had it active in about 22 states now, and we found it to be really effective with the behavioral health population. It was originally created for the behavioral health population. But that said, there's the ALA, American Lung Association model, and there's a few others out there that, even if you want to email us, I'd be happy to send some other ideas on that.
Okay. Then Brian asked if there are any recent updates to NRT or medications for pregnancy.
Not so much. I mean, it's still that what we basically the guidance continues to be is that to the extent possible, if we can help pregnant moms use behavioral strategies and not NRT, that's the best option. But for a lot of folks, that's women that is not going to be that's not going to work fully. And we know that if, for a lot of women, NRT can be effective. It's not as effective for women as men, and it's not as effective for pregnant women because they metabolize NRT so quickly. But trying NRT is so much more, it's going to affect the, fetus much less than smoking combustible products. And so that's kind of the second line, and that all the guidance that I continue, and I review that pretty frequently, that seems to be where we land still.
Okay, so I'm going to open it up to Michelle.
Oh, Michelle's there.
Let's see. Okay, well, I'll move down to the questions. Don't know what happened. So it says, Kat says there are homeopathic specifically associated with withdrawal effects. Even if for placebo effect, do you recommend trying natural alternatives?
From our, this is what I would say is to that, is that we have to go from the evidence base from our agency, and the evidence base isn't very supportive of, we just don't have the evidence base for a lot of those alternative medications, or I'm sorry, alternative medicines, alternative strategies, including hypnosis doesn't have a high level of evidence base. But my feeling from a motivational interviewing perspective is that we have to meet people where they're at. And so if someone strongly believes in those types of strategies, and we know that it's not going to, it's at least safe, that, we're not putting people in harm's way, that I'll often start with that. An example of that is youth, that with youth, if we ask them what they want to quit smoking, they'll say, I want, peer support, I want technological support, and I want NRT. And NRT, we know with youth, at least from the evidence base, isn't real effective. But from an MI perspective, I would still be apt to start with that, because that's what they're asking for, and I know it's not going to harm them.
Okay, and then Andrew is asking if there are any other primary shared decision toolkit resources.
Yeah, I'm looking at primary care shared. So we have our workflow. It looks like, Andrew, you looked at that. We do have other workflows. So Andrew, why don't you email us, and we'll see if we can dig up some other resources that you might find useful.
Mark asks, do you have any experience with treating Native American populations in overcoming tobacco dependence?
I would say I don't have expertise in that. I've done some work in that area, but there are some really good programs out there. And some of the quit lines are doing excellent work in that regard. And so really looking at Native rituals and weaving those in, and prayer circles and so forth. And we've done some, actually, what we could send you is we've done some literature review on that, on what the practices are out there. But I would actually recommend looking at the Minnesota's quit line, and they've done some amazing work with the Native American population, and then also National Jewish has as well.
Okay, and it looks like I missed one from Larry. Is there any of the training specific to MH peer support staff versus therapy staff, LMPs, etc.?
Yeah, a lot of it's when we were working with MH peer support staff, it's just really making sure that they have the fundamentals as far as self-care and boundary issues and a variety of other professional issues. And if they have that, which we start with, and often we'll bring in peer groups to do that training, then the training after that, as far as the evidence-based practices, we found looks very similar. We actually used to break them up, our trainings, into peer trainings and then other interdisciplinary provider trainings. And after a while, we realized that the interdisciplinary providers didn't know any more than the peers, and we had to teach them the same way. And it really kind of also has a secondary effect of reducing stigma and making sure that everyone understands they're on the same treatment team.
Okay, are there any other questions? Did I miss any? Cynthia, do you still have a question?
No, do I need to lower my hand? Sorry.
Well, I should have done that too. Okay.
Good. Well, hearing none, again, you can always email us. Let us know if you have additional questions. We always like comments too. But we very much appreciate you joining in today, and we hope you chime in and join the next 4 webinars that we're doing as well. Have a wonderful day, everyone.
So as a reminder, the next webinar is on February 26th, and it's called Low Burden Cessation Strategies for Resources-Strapped Agencies, Intervention Alignment, and Effective Community Referrals. So put that on your calendar, and thank you, everybody.